session now. Okay, we are recording. Remember that all session materials in today's recorded session will be up on box.com. And I should have sent out a link to everyone. If you did not receive that link or you don't have access for whatever reason, reach out anytime. We'd be happy to talk with you and help with that. We will go ahead and get started. For anyone new, again, we're the Yale Survivorship team here. Maybe we can just go around quickly and just say who we are briefly. I'm Jevin, the PA with the program.
Angela Corella, the clinical social worker.
Scott Capozza, physical therapist.
Lake Williams, program coordinator.
Reed Mishar, second year MPH student. Igor Dombrowski, second year med student.
Maura Harrigan, dietitian.
And Dr. Tara Sampton, the medical director.
All right, thanks everyone. So we can go ahead and get started. We're going to flip things around today and start with our case presentation first. So let me jump into that. I'm going to share the screen with everyone. All right, and again, this is Jevin Britta here again talking to you. So, like I said, if you have any concerns, feel free to jump in anytime with any questions. I'm going to go through the case presentation here, and then we'll give each of our members here a chance to talk about it. Today we have Mrs. R. She was a 63-year-old female survivor. She was diagnosed back in 1995 with DCIS, or ductal carcinoma in situ of the right breast. She had surgical resection of the breast of that tumor, or that DCIS at the time. And then in 2000, she had DCIS of the left breast and had an elective bilateral mastectomy, so both breasts were moved. Unfortunately, then in 2007, she was diagnosed with a new primary invasive breast cancer that was estrogen receptor positive, progesterone receptor negative, and HER2 positive. Stage 1. And the final consensus was that it was likely leftover residual breast tissue and the axillary tail that was there. And that's how that cancer came up as recurrence, or as a new primary cancer, excuse me. She did receive adjuvant radiation in the past as well to the right breast for the DCIS in 95 with the excision. She received adjuvant Taxotere, carboplatin, and Herceptin in 2007 initially after the invasive cancer, but then she was switched to Taxol and Herceptin due to numerous side effects. And she started on an aromatase inhibitor, exemestane, or aromasin, and had some musculoskeletal pain back in 2007. So when she had come to the survivorship clinic, she was 4 years out from her time of diagnosis. We chose to present this case because she had significant fear of recurrence that was negatively affecting her quality of life. The challenges that she presented to us were with regards to her strong health belief in finding the right supplements and diet to assure risk reduction. And at the time, we didn't have the intake to screen for her two primary concerns. It wasn't standard operating procedure. So we didn't get those ahead of time as we would now. So some information about her social history. She lived alone. She worked as a librarian in elementary school. She was a former smoker, did not drink any alcohol. She had not gotten any exercise and was not active with 150 minutes of exercise per the recommendations a week. Her pre-diagnosis weight through her treatment and afterwards was at 140 pounds. She did not get 5 or more servings of fruits and vegetables each day. Her vitamin, supplement, and herbs use was pretty significant. She took a total of 50 pills and 241 drops of various herbal preparations a day. She did not have any other comorbidities, and her past cancer-related family history was significant. Her mother had metastatic breast cancer and was diagnosed at age 54 and passed away at age 63. And coincidentally, this was the same age that she had presented to us in clinic. So this was a major concern for her with regards to a fear of recurrence. Her brother had esophageal cancer at age 38, another brother lymphoma age 56. Her maternal grandmother with stomach cancer, paternal grandfather with throat cancer, and she had genetic testing for this done in 2000, and that was negative. So that was everything we had for her from the case presentation forum standpoint, but I'm going to turn it over to our team here, and we'll start with Tara.
Great. I think there's a few slides that kind of guide us through the discussion.
Sure.
Let
me just go back.
you go, yeah. So again, I'm Tara Samt. I'm an oncologist, and I see patients in the Survivorship clinic. I also see patients in an active breast cancer setting. And you know what I find very interesting about this case is kind of her worst fears did come true. So we spent a lot of time in oncology talking about non-invasive breast cancer, which is what she was diagnosed with twice. Being a really, mostly benign thing, and it's stage 0, and some people don't even think it should be called cancer. So a lot of our language that we use to describe DCIS is reassuring to the point of dismissing it sometimes. And we still needs treatment, and we talk about all of that. But the truth is, her risk of recurrence after her first treatment, assuming she took the medicines that she needed to take and she followed through with all the recommendations, was somewhere around the order of 8%. So the fact that she got a second episode of DCIS, her worst fear did come true. So 92% of women after that would not have a recurrence, but she was in that 8%. And so what we find in medicine, right, in our medical consultation is you try to give people statistics. They say, it doesn't matter to me. If it's a 1% risk, I'm in the 1%. So all of your 92% don't recur isn't reassuring. And I think I have a healthy sense of respect based on cases like this, that's a very real thing for patients. And then of course she ended up with the most rare recurrence or new primary, which is a new invasive cancer in 2007 after bilateral mastectomy. And so when we're counseling people on a medical perspective, that risk of recurrence is about 2%. So it's not 0, but 98% risk reduction in removing the breast tissue after a cancer diagnosis like this. So she really, her fear wasn't based in fantasy, and it actually did kind of manifest itself throughout her over a decade of treatments. So those are some, I think, important things to recognize from a medical perspective. The other thing we know about fear of recurrence is that, and this case illustrates that, it doesn't really matter your actual risk. So women with DCIS are just as afraid as women with stage 3, and sometimes women with stage 3 don't think about it at all, and it doesn't really interrupt their life. So we're going to talk more about that. Angela's going to go into all of that. So this is a great case from a medical perspective at highlighting the realities. People do recur.
All right, thanks, Tara. Maura, I'm going to go ahead and bring up the slideshow again. Okay.
Okay, this is a very fascinating case from a nutrition standpoint, and it shows how fear of recurrence can actually translate into fear of food. That something I ate caused my cancer, something I will eat will cause my cancer to return. And in this case, it went to an extreme where she kind of gave up on food out of fear and went towards supplements. So that's, often the question people ask when they come to clinic, what supplements should I take? And just, again, so we're all establishing a baseline here. The American Institute for Cancer Research and the World Cancer Research Fund state do not use supplements to protect against cancer. And all the dietitians out there know that we promote using whole foods to obtain our micronutrients. So this isn't new to the dietitians, but to the non-dietitians, you may not realize there's this really hard stance against supplements, but the usage is high because the myth is out there that more is better. And a lot of patients believe this. So our job is first to make sure no harm is being done in terms of the supplements that are being used. But used they are. You can see that the projection in sales is going to be 300 billion by 2024. It's a hot market. It's unregulated. These are pharmacologic substances that are not regulated. So it's an issue. So as dietitians, when someone comes in, as you saw, she had an amazing amount of supplements she was taking. So evaluating the supplements, the first question is, well, how much is needed? And there are standards that we use. They're called dietary reference intakes. And they're tables that are set up by the Food and Nutrition Board of the Institute of Medicine. And they're set up by age and gender. And the amounts that are identified are what's considered a daily intake sufficient to meet the requirements of 98% of healthy adults in that age group. So that's often what I do when someone comes in taking a lot of supplements. I'll ask them, why are you taking it? Were you instructed to take it? The answer is often, well, someone told me, a friend, a coworker. And I'll say, well, why are you taking a particular dose? And they'll say, I don't know. It was what I took off the shelf. So oftentimes, just taking out the dietary reference intakes table and showing them, well, for your age and gender, you need 30 milligrams, and the dose you're taking is 300 milligrams. And it'll cause them to pause. But well, then they'll even say, well, then why is this product even on the market? And I'll say, that's a good question, because it's a business. So one way to kind of rein in supplement use, I find, is showing people exactly what they need and compare it to what they're taking. And oftentimes, this is a surprise to them. Now, the next piece of this is, how much is needed, but how much is too much? And there is such a thing as too much. And again, there are tables set forth by the Food and Nutrition Board, and we call them tolerated upper intake levels. So it's the highest daily intake likely to pose no risk of adverse effects. So this is pretty powerful when you show these numbers to people and that the doses they're taking, and sometimes the doses can be from multiple preparations. So they have something in their multivitamin, then they have something in their B complex, and then they have something else in this herbal preparation that someone gave them. And you can add up these individual doses and it can exceed the tolerated upper intake level. Again, presenting it in that way often will get people to rein in their supplement use. And the last thing to consider is, again, remember, these are pharmacologically active substances. Will they interact with other medications that the patient is taking? So on the next slide, I like to describe this to people as like merging traffic, that these supplements can share the same metabolic pathways as their other medications. And for those who want to know, CYP4 is usually the most common metabolic pathway that's shared. And what happens is, just like with merging traffic, it causes congestion. The supplement may increase the dose of the other medication or decrease the dose of the medication, depending on how the merge is going. So again, presenting this to people will help them kind of rein in their supplement use. And there's a database that I put there, the Natural Medicines database, where you can type this information in and it will pull up the interactions for you. So that was kind of a primer on how to evaluate quickly supplement use, and I'd like to open it up to folks out there. Does anyone have any questions or comments? You can type it in the chat room, or you can raise your hand and flag us.
Feel free to unmute yourself if you have a question. Happy to field anything. How are we doing on the chat, Scott?
Everybody's quiet on the chat room right now.
That's because there's so many dietitians out there. They're like, oh yeah, let's move this along.
But that was all good stuff, though.
What's the average time it takes?
Polly.
Oh, good.
Go ahead,
Holly.
Holly.
Oh, hi, this is Holly from Oregon. Can you hear me?
Yep.
Yes.
Yes.
So the area that I live in, we're in a university town, and we do have several integrative practitioners around. So I really do, I would say probably 90% of the time on patients, this is one of the questions that they have. What can they do? What can they take? And we do really try and work with their integrative practitioners, but it's tough. You know, they come in with things that are adaptogens or several different, so it's hard to really know. I really appreciate the resource you gave, but it's, sometimes we have great resources in terms of farming community and organic farms around us, and so you, in theory, think people can get those nutrients from their food, but there's still this I guess interest or I guess lack of trust in food and more in taking something from a bottle. So it's kind of hard to balance sometimes. It's a lot of times patients really do feel like their symptoms are improved because of what they've been prescribed, but it's hard to kind of guide them in terms of what really is necessary and what really is helpful.
I mean, and if I can just hop in there, Holly, I totally agree with you. This is Tara, the director of the clinic, talking. What I hear is so many patients in Connecticut use naturopathic doctors, and I understand like why they do that. But what I find when I talk with them is that they get the supplements from that person, and so they totally trust the content and. Well, the doctor is prescribing it, and it's coming from her office. And I said, but does she make it herself? And they say no. But so they're paying hundreds of dollars a month, not just for the visit, but also for the supplements. And I try to focus on the fact that that's fine. It's just that it's not regulated, and we don't know. There's no way to double check what's in those pills. Which is why it's so important to think about the food sources, because you can understand more where your food is coming from. And patients are kind of blown away sometimes with they assume that the supplements they buy from their naturopathic doctor are regulated. So that's just from a medical perspective, some ways that I try to talk about it. I never say that person doesn't know what they're doing, because I feel like that just breaks a relationship and really pits one provider against another provider. But I do talk about the fact that it's not regulated, so you can't tell. And when we talk about how 100 supplements off the shelf of black cohosh were tested, and only one of them contained the black cohosh that is said on the bottle. That's an example that kind of hits home to patients. One more, do you have other things to say about that?
Well, in this particular case study, she was spending over $1,000 a month on her regimen, and her day revolved around taking these pills at prescribed times. And I run into that a lot when patients come in with a plan from a naturopath, which is heavy supplement use and specific foods that are highlighted. Honestly, there's nothing wrong in the information, but it often has nothing to do with the person and their life and their circumstance. And it's not, and that's something that, again, dietitians do very well. I just have to, shout out to the dietitians that we know how to adapt to the patient's circumstance. So even a few weeks ago, we had a woman who came in, young woman, early 30s, had 3 young kids at home, went to a naturopath, had this 5-page plan with all these randomly assigned foods and supplements, and she broke down crying with me because she couldn't follow it. It wasn't sustainable. And then she was having to do this and feed her kids something else. So we kind of came up with a plan that worked for her and her kids. And so again, trying to take those plans and make them sustainable and applicable to a person's circumstance.
Yeah, I think, I know our dietitian is just, I mean, we have a little crown for her because she's so amazing. And she, one of the things that has really helped with some of the education piece that, still maintains the support of patients in doing what they want is she helped develop a program called That's My Farmer, and she's works with the local farmers markets and has patients come in, I think it's 6 different classes, and then they get a little gift card to go to the farmers market and redeem it. But she's really worked on focusing on the things that patients said that they were doing for supplements and pointing out the food sources that they can get that. So yeah, I agree. Where would we be without our dietitian? So true.
We'd love to hear from her too.
Yeah.
That's great.
Yeah.
Thanks, Holly. Appreciate the feedback there. Okay,
Yeah,
so we're going to jump back into the slideshow here. Let's see. Okay.
I think the next one is Scott.
Yep. So
Yeah.
Scott, go ahead.
Yeah, so just really quickly specific to this case, obviously after 3 different diagnoses, she was apprehensive about how can she live a healthy lifestyle physically moving forward. And so at that time, I was going off of the American College of Sports Medicine recommendations for exercise, which at that point was 150 minutes a week of cardiovascular exercise. But I had to take this also a step further for her, to get her to try to get some buy-in to realize that not only is cardiovascular exercise or just exercising in general going to be good as far as trying to decrease her risk of either recurrence of the breast cancer or developing a new cancer, but trying to also look kind of globally to say, not only is this good for you for your cancer recurrence, but also maintaining your blood sugar and maintaining your blood pressure and that sort of thing. And so kind of looking at global health, not just looking through one prism of cancer. So to try to instill in her the idea that, this is exercise is going to be good as far as trying to prevent cancer from coming back, but overall making sure that you live a healthy life, as far as all the other systems in the body. So, and then so for her specifically, I needed to take some time to figure out, what did she like, what didn't she like as far as activity was concerned, and come up with tangible short-term and long-term goals. Because 150 minutes is a big number for somebody who's not exercising. So to be able to break that down, and we can get into that a little bit more with the didactic later on. But that's what I did with this particular patient.
And, so thanks, Scott. Next we had Angela, who's going to talk a little bit about the case.
Okay, so this is Angela. I did not have the opportunity to meet this woman because she came to the Survivorship clinic before I was part of the clinic. But just sort of based on what I know about her and what information has been shared, it's very clear to me that she is having or had some pretty significant or highly disabling levels of fear of cancer recurrence. And just, kind of just based on her behaviors and her choices that she was making, we heard from Maura that she, was spending thousands of dollars on supplements and, I'm sure was doing a bunch of online researching within the community, and that takes a lot of time, it takes a lot of energy, and clearly is impacting her quality of life to be doing, those behaviors. It almost seems obsessive, to some level. I know that, there are some risk factors here with the, breast cancer and the 3 episodes, with the past family history of all the different family members with cancer, her mother being diagnosed with breast cancer and then passing away around the same age of her own diagnosis itself. Just based on what I know about her, she was having significant sleep issues. She was also having relationship issues. And again, all of it's really just stemming, I think, to this fear of cancer recurrence was driving the behaviors that she was, the behaviors that she was exhibiting, particularly around the supplement and her food choices. I know that she was strongly encouraged to seek mental health counseling, which she declined. And even over the years, other providers encouraged her as well, and she continued to decline. So, so this again is a very good example of somebody that's having severe and disabling levels of fear of cancer recurrence.
All right, thanks Angela, and thanks everyone for sharing a little bit about the case and the different perspectives on it. I want to open the floor to everyone else before we jump into the didactic portion of today's session. Again, invite any of you for discussion or questions that you might have with regards to the case or fear of recurrence in general, or any other specific questions that you might have. Go ahead and you can unmute yourself if you're on the call with us. You can press *6. If you're on the video chat, you can unclick mute in the bottom left-hand corner. There's also the chat window as well. You can click on that to type in any questions or comments. Okay. All right, last call. If you have anything that comes up, feel free to.
We'll have some questions at the end.
Yeah. So feel free to jump in anytime, but we're going to go ahead and go into the rest of the presentation here. And so for that, once I get it up, we will turn the floor back over to Angela. Yeah. Oh, just go ahead and click on the screen.
Okay, so let's talk about fear of cancer recurrence. Fear of cancer recurrence, many of you may already know and are familiar with this definition, but it's really about fear or concern, just really relating to the possibility that cancer will come back or will progress. And it's important to note that it's one of the most commonly reported psychological problems reported by cancer survivors. And it's one of the most prevalent unmet needs, and 30% who've been surveyed have said it's a significant unmet need for help in managing their fear of cancer recurrence. Again, it affects between 50 to 70% of cancer survivors across all types of cancer. It's important to know it's very common to experience some degree of fear of cancer recurrence. I think 75% of the people we saw this morning had some level of this. Again, 22 to 87% of the cancer survivors will report a moderate to high level. On average, it's around 49%. Between 0 and 15% report high clinical levels of fear of cancer recurrence. And again, as Tara pointed out earlier, it's not strongly linked to prognosis and may even occur in individuals with a relatively good prognosis. And I also, besides working in the survivorship clinic, work with Dr. Sam and Tara in the Smilo Breast Center. And I would definitely say that women who are early stage breast cancers, stage 0, stage 1, have higher levels of fear of cancer recurrence than women who are stage 3 or even metastatic disease. So just based on my own personal experience and working in that clinic over the years, I've noticed that as well. It's important to note that with fear of cancer recurrence, it really fluctuates on a continuum between functional as well as dysfunctional anxiety that does impact all areas of someone's life. Lou in 2018 found that fear of cancer recurrence, patients will exhibit psychological distress, sleep disturbances, poor concentration, reduced quality of life. These are the patients that do excessive reassurance-seeking behavior, and because of that, it can increase healthcare costs. And of course, in extreme cases of fear of cancer recurrence, patients get diagnosed with anxiety disorders, post-traumatic stress, and even depression. So what does fear of cancer recurrence look like? Well, in the mild form of it, it's really patients who have just those occasional thoughts about cancer. They have those triggers, like they're coming in for a follow-up appointment, they hear a family member or a friend has cancer. If they have breast cancer or had breast cancer, October is Breast Cancer Awareness Month, so that oftentimes creates a lot of anxiety with breast cancer survivors just because there's pink everywhere. Usually with mild forms of fear of cancer recurrence, it improves over time, and overall patients are coping well and managing. With moderate to severe levels, patients may experience more frequent thoughts about cancer, perhaps more than once a week, in the absence of triggers. So all of a sudden they start thinking about it, and it's really hard for them to not think about it. And it's hard for them to control those thoughts. And this can be quite distressful. And then for 7%, fear of cancer recurrence is severe or highly disabling. So this would be the case presentation that we discussed earlier. Constant intrusive thoughts, and, can be happening regardless of the prognosis, an inability to plan for the future due to worry that the cancer will disrupt their plans. I had a patient several years ago who had a very excellent prognosis, and he was actually saying to me, I don't think I can retire and go buy that condo in Florida that my wife and I have planned to do our entire lives together, because what if my cancer comes back? So he was having a hard time moving forward, even though his prognosis was really good. They may over-monitor for signs of cancer activity, again, constantly searching online for information. Again, this woman that we spoke about earlier, again, overusing the healthcare system for reassurance, a preoccupation that the cancer will recur, will come back regardless of prognosis, and they have unhelpful coping strategies. Sorry, I had a problem with the mouse. Okay, so these are some risk factors. And again, the woman that we just presented had definitely several of these. Patients that are younger, so AYA would be young adults, and that's actually anybody between the ages of 18 and 39. Higher subjective risk perception, more severe side effects, anxiety conditions or past mental health issues, past trauma, or relatives developing or dying from cancer. So a study in 2019 by Goetz looked at 1,002 cancer survivors that were 5 years after diagnosis, and they found that 17% of those patients had high levels of fear of cancer recurrence. It's interesting to note that they also found that patients who received hormone therapy, so again, breast cancer survivors, are found to have higher levels of fear of cancer recurrence. And even though fear of cancer recurrence does in fact slightly decrease over time, they also found that even up to 10 years after diagnosis, it's still a common mental health problem amongst survivors. Another survey looked at 1,295 breast cancer patients, and they found that 60% of doctors don't even actually ask patients about fear of cancer recurrence. And they also found that if oncologists or nurses are able to, spend some time meeting with the patient, it really helps reduce suffering, improve communication and rapport, and prevent the development of severe levels of fear of cancer recurrence. So the next couple of slides really just review and go over some things that providers can do. So what can you do if you have a patient who's experiencing some level of fear of cancer recurrence? Well, obviously, it's really important to just respond, to be present, to be listening to their nonverbal as well as verbal cues about, they're expressing anxiety and depression. Verbally ask the patient at follow-up appointments if they're having levels of fear of cancer recurrence. Reinforce that it's very common and that it's very normal. And believe it or not, even to some degree, by having some level of anxiety or worry, it actually encourages patients to make healthy lifestyle choices as well as to go to follow-up appointments. It's important to emphasize to them that by talking about it, it actually helps reduce, the stigma about anxiety. So it's important to effectively communicate the prognosis to patients, as well as the signs and symptoms of recurrence that may not likely be related to cancer. Recommend, obviously, healthy behavior choices such as exercising, eating healthy, smoking cessation, mental health counseling. Patients who are informed about these things, do well, but those patients who aren't informed about these things actually report higher levels of fear of cancer recurrence. So some things that you can do. So if you identify that a patient is having any level of fear of cancer recurrence, you could refer them to your local cancer center or survivorship clinic if one exists in your area. If not, you could refer them to your hospital or your cancer center, to a clinical social worker, or if you have a psycho-oncology clinic or providers, suggest a survivor seek community mental health counseling, refer them to local support groups, and again, encouraging them to engage in healthy lifestyle choices. So, psychosocial support. So for my role as the clinical social worker in survivorship, so these are just some of the things that I do. So when I meet with a patient, I really give them an opportunity to talk about where they're at, provide them an opportunity to be heard and to be listened to, provide emotional support, utilize the results from my intake and screening tools. We've discussed those in here before, the brief fatigue inventory, the distress thermometer, actively listen and normalize their feelings, emphasize that they're not alone. I can't tell you how many times I will say to a patient, I have heard exactly what you're saying from so many other survivors, that how you're thinking and how you're feeling is very normal for cancer survivors to be thinking and feeling this way. And it's like a huge sense of relief when they hear that. It's important to discuss the social, emotional, physical, spiritual, and sexual impact of cancer survivorship and how all of those actually are intertwined and overlap with one another. I complete a psychosocial assessment as well as assess for coping strategies, fear of cancer, recurrence, anxiety, depression, and PTSD. So these are just some of the theories that I pull my social work interventions from. I really want to highlight to you meaning-centered psychotherapy. This was developed by Dr. William Breitbart in the year 2000, and it really helps bring about purpose and meaning to the life of survivorship. I can't tell you how many times I've been meeting with a patient and they'll say to me, I feel lost. I don't know where to go from here. My life, my priorities have changed. I think I'm going to quit my job that I've been working in the last 40 years and I want to do something different, or I want to be a part of something bigger than myself. I want to volunteer. I want to give back. And so when patients are expressing these things to me, that's when I'm able to incorporate these meaning-centered psychotherapy techniques. Obviously, cognitive, behavioral, the connection between thought, feelings, and behaviors and choices is very important. Positive psychology, as well as mindfulness. Those are all very important, helping patients focus on staying present in the here and now and living each day to the fullest. So some of the things that I'll do is after meeting with the patient, referring them to individual mental health counseling or psychiatry, referring them to local cancer support groups, talking to them about cognitive behavioral strategies for sleep, as well as sleep hygiene strategies and techniques, help them reframe and focus on what is and what isn't in their control. I think every person I spoke to today, this was the crux of most of what we talked about, is let's talk about what you can and can't control with regards to fear of cancer recurrence. So obviously, exercising, eating healthy, hydrating, again, focus on meaning and purpose in life, encouraging them to practice mindfulness, meditation, and yoga, and learning strategies like breathing, guided imagery, and stress management are all very helpful. Okay, so any questions at this time related to fear of cancer recurrence?
I'm actually going to jump in with a question.
Okay.
That came from Sarah and the UConn team. I think this actually goes back. By the way, that was amazing.
Oh, thank you.
Great
Very good.
didactic. This actually goes back a step to our case presentation. So Sarah and the UConn team wanted to know, I guess, with respect to the supplements, would you treat this obsession with supplements as an addiction? And if so, what would be your approach?
You have some slides on this, right?
Yeah.
Yeah, we do kind of get to that.
Yeah. Hold that
It's coming.
And
Yes.
it's next, actually,
It
right?
is.
Okay.
Perfect.
Perfect timing.
Queued up.
All right.
So there are a few more nutrition topics of how fear of recurrence manifests itself in nutrition. And
Sorry,
slide.
technical difficulties.
Skip one. No.
I wonder if this started.
Oh,
There we
here
go.
we go. All right,
There
we'll
we
start
go.
here. Okay. So, all right. So, in addition to supplements, often the number two concern about cancer recurrence is, does sugar feed cancer? That's often it's a myth out there, and but it's kind of like beyond myth. You know, people really believe it. So the answer is, does sugar feed cancer? The answer is no. But do we need to limit added sugars? Absolutely. I mean, it's a problem in our food supply that food manufacturers are deliberately adding sugars into the food supply. So we do consume too much for overall health purposes. And actually, American Heart Association came out with recommendations for added sugars that you can see on the slide. And I like to talk about it in terms of teaspoons. That's how people understand sugar, but kind of limiting added sugars to 6 teaspoons a day for women and 9 teaspoons a day for men. But the next slide, Dr. Sam and I were talking about this New York Times article about sugar and cancer, so I Googled it, and this was the one that came out a few years ago, and this is what came up. So this idea has been around for a long time. From 1887, they talked about that sugar feeds cancer, and it was the private physician of the Crown Prince, German Crown Prince, and this physician was saying that his throat cancer was due to the sugar content in his diet. So this has been kicking around for a long time. And in the next slide, in this, that's very good.
Just to emphasize.
So in this archived article on the next slide, they debunked this. You have to go to the next slide. You can't do fancy, Devin. Okay. All right. See, you're getting a little too fancy. So the idea that I love how the in this 1887 article, this whole topic was handled in a very brief paragraph, and it was dismissed just as briefly. But that I liked how they say how their New York medical men debunked this cause and effect. And that is, and with the same explanation that we give today, that, all cells are fueled by blood glucose. So it's not this direct line. But just advance the slide, Devin. That's all you got. So what I like to say how I try to explain to people, and I must have given this example, this explanation 3 times this morning with patients in the clinic, was that it's not the connection between diet and the cancer cell is not a direct line, but it's more the influence of diet that has on the development and progression of cancer, that the normal cell that would mutate and turn into a cancer cell, that this takes place over a long period of time, and that the quality of your diet influences this process, that a good and nutrient-dense quality diet will slow down this process, and a poor quality diet won't impede this process. But it's not a direct cause and effect. Some people come into clinic thinking, oh, and I couldn't help myself, I ate that Snickers bar, and I burst into tears because I thought my tumor was going to grow back the next day. So it gets to be that extreme in terms of fear of recurrence. So that's why I spent a lot of time trying to tease that out, that it's not this direct cause and effect, but that healthy eating and exercise, as Scott will get to, has a positive influence in terms of slowing this process down, but it doesn't prevent it in 100%. So next slide. Now to answer the other person's question, Sarah, that there's actually, in terms of, this can become an obsession. In fact, there's even a new eating disorder that's being proposed, and it's called orthorexia nervosa, and that there's compulsive behaviors like we saw in this case study with self-imposed food restrictions. And the goal is that it's to promote optimal health. It's not to lose weight as you would normally think of anorexia nervosa is a restriction of food for weight loss. This is to promote optimal health. And that when they violate their own self-imposed dietary rules, it causes an exaggerated fear of disease, like biting into that Snickers bar and thinking you cause your tumor to return. and that it can be accompanied by anxiety and shame. And this can escalate over time to eliminate complete food groups, as we saw in the case study, where the woman was down to about 5 individual foods, but 50 supplements. And also practices include excessive fasting, purifying detoxes, and as we saw, excessive supplements. And again, what differentiates this is that it's based upon the ideation of healthy food, not to a desire to lose weight. Now I'll hand it over to Scott, unless anyone has any questions or comments about that.
Sarah,
Questions?
Sarah, does that answer your question?
Sarah, I'll unmute you and let us know if you felt like you had any other lingering thoughts or questions.
No,
Yep.
we're all set. Thank you.
Okay, thanks.
Okay, so
Okay, we'll jump back in. Okay,
All right.
go ahead, Scott.
All right. So, go ahead. You can advance that. Yeah. So for physical activity and fear of recurrence, this is an area that's actually just has been updated as far as exercise recommendations for cancer survivors. This just came out a couple of weeks ago, the middle of October. The original American College of Sports Medicine recommendations came out in 2010. They were just updated in October, and it was a multi-group approach. It was the American Cancer Society, ASCO, the American Physical Therapy Association, all the greatest minds in oncology got together and updated this. And they were talking about how we can now start to prescribe exercise like we can prescribe medicine. And so, and they found that one of the interesting things they found is that that for somebody who is experiencing anxiety, someone who's experiencing anxiety from cancer and fear of recurrence, that you can prescribe aerobic exercise for that person to help decrease the effects of fear of recurrence. Interestingly, they found that you couldn't necessarily just prescribe strength training. That strength training alone didn't necessarily have the same effect on decreasing fear of recurrence as aerobic exercise. You can put them together. So that third column there, combining aerobic exercise plus resistance training will help as far as reducing the risk of cancer-related anxiety and fear of recurrence, but not just the strength training alone. So I thought that was one of the many interesting things that came out of these new recommendations. Now I'll be getting into these new recommendations more over the next couple of weeks when we talk about fatigue and that sort of thing. So this is just to kind of set the table, so to speak. But yeah, specifically, for fear of recurrence, we can now look at this and say, okay, if this is how somebody is presenting, we know that we definitely want to get them to be doing more aerobic type of exercises to have the most benefit in addressing this. And briefly, to dovetail off of that, to say, when we tell our patients, we want you to move more, we want you to get some cardiovascular exercise in, and the patient comes back to us and says, well, how do you want me to do this? These are some of the strategies that I will talk with our patients about, as far as writing it down and tracking your exercise so that you can actually show progress over the course of several weeks and several months. Most of us at this point probably have Fitbits and Apple Watches, which will help track our steps and our miles that we walk and that sort of thing. But maybe for some of our older cancer survivors who don't have that kind of wearable technology, then we could just go traditional paper to pencil, as far as saying, on November 6th, I went for a 10-minute walk, and then just continue to chart that over the course of the next several weeks and months, because that's really powerful to show our patients, hey, look where you started out from, and look where you are now. Look at the progress that you have made. I will also tell our survivors that it's easier to exercise with somebody. especially if you say to somebody, okay, let's meet at the trail at 8 o'clock on Saturday. Let's go for that walk. You better show up, because if you're not there by 8:10, you will get an angry text saying, I'm here, especially now it's colder out. I'm ready to go. Where are you? So, so sometimes putting the onus on somebody else or having to account for somebody else will make you show up and get your exercise in. This morning, again, at Survivorship Clinic, I was talking about setting specific goals as far as, if you put something on the calendar, whether it's signing up for a local 5K, if it's signing up for a charity bike ride, if it's even doing something as radical as doing like a fun active vacation, like a trip to the Grand Canyon, or kayaking through the Everglades or something like that. Once you plug down your registration fee or you pay for those plane tickets, you're committed. And if you have it on the calendar, then you are more likely to stay focused moving forward with your exercise. And lastly, I tell everybody, cancer survivor or not, when it comes to exercise, you really have to plan ahead. And I do this in my own quest to try to maintain my own 150 minutes a week of exercise. The team will tell you that I am notorious for changing at lunch and going for a run and coming right back and using some baby wipes and getting ready for the afternoon session. But that's the only time of the day that I may have to exercise. And so I have to get creative. And so, and so you guys as the providers, you may be asked the question, well, when is the best time to exercise? And honest truth is whenever you have time. But there is time in the day. And so I will tell people, on a Sunday night, look at your week ahead and find out where you can plug it in, because there'll be some place in your schedule. Even if it's bring your car for an oil change, you've got 30 minutes while the car is getting the oil change done. That's an opportunity to go for a walk.
All right.
Great. So I guess just in the last few minutes, a few parting thoughts from a medical perspective as it relates to fear of cancer recurrence. I think it's really important to go over with patients what their diagnosis was, clarify sort of what they think is actually the stage or the grade, and frame the risk of recurrence several ways. So while it might be independent of their actual risk, I do think it's important that we talk to patients, on one hand we're saying, oh, your risk of recurrence is 8%. But we need to say it both ways, and the vast majority of women, 92%, do not recur. I think patients need to physically hear it in both ways to really internalize what this means. To be very upfront about what the surveillance strategy is really important. And a lot of our breast cancer patients in particular, they want to know, are you going to get a PET scan every 3 months? How are you going to know? And it's easier to just say, sure, yeah, I'll do labs every time I see you, and somehow that's gonna make sure you didn't have a recurrence. What's harder is to say, actually we don't have a test that really detects it at the cellular level, and we know if you're feeling good, the likelihood that it's recurred is very low. Now for the highest level of fear of cancer recurrence, that might not be good enough, and I tell my patients that we will work with you to try to get you the reassurance you need so you can function. And I think as physicians and providers, we can really stress, this seems like it's really impacting your functioning. I think you'd really benefit from some professional mental health. And say it out loud. And I think patients appreciate that level, whether or not they act on it. We see various degrees of uptake with that. But I think, to me, I try to tell my patients, I don't want you to be paralyzed with fear. So we have to figure out a way that you can live with that. And, on the last thing I'll say is I have a long-term cancer clinic that happens sometimes in conjunction with the Survivorship Clinic. And I know that women who are 5 and 10 and 15 years out, sometimes it crosses their mind, mostly maybe when they're coming to see me. But the vast majority of women, it's not on the top of their mind. And so telling my recently diagnosed patients that this does fade away and it's not your number one concern on average, I think can be really reassuring.
Thanks, Tara. And I think do we have some questions in the chat? I saw a few.
The team from Maine posed the question, will exercise 15 minutes 6 times a week provide the same benefit as 30 minutes 3 times a week? And I said probably, consistency is important. If somebody can exercise 6 times a week, that's fantastic. And then if you can work with that patient to say, okay, 15 minutes, can we push that to 20? Is it possible to gradually push it to 25? It's not going to happen overnight. We don't expect it to happen overnight. But yeah, I mean, if you can get somebody to exercise 6 times a week, that's fantastic. And I think that's one of the biggest challenges is, so many people, what happens on January 1st, everybody signs up for the gym, they're really good for the month of January, then everybody kind of tails off afterwards. And so when we're talking about lifestyle changes, I mean, that's really the key to keep that consistency going.
That was a great question.
Yeah.
Thanks for that. Does anyone else have any other points of discussion or questions? We have about a minute or so left here. Got time for maybe one more. How are we on the chat, Scott?
We're all caught up on the chat. If anybody else has any questions, I want to type them in quick.
I'll just take a moment here. Did you have something
Nope.
else? Okay. I'll take a moment here just for a quick few reminders before we wrap up. Just remember, an email will go after the session with a post-session survey. There will also be the case presentation form attached if anyone should want to present on someone they had seen in their own clinic with any concern. Next time we'll be talking about fatigue, but any topics, of course, for any survivor you might have seen is welcomed. Happy to help with that case presentation form. Happy to help go through a mock presentation if you'd like. Highly encourage it. We'll always have something ready though in case no one wants to do that. Did we have something else?
Last, the team from Maine, if we could touch upon this for the last minute here, she wants to know how do our patients get referred to us? And I think we talked about that a little bit in the nuts and bolts, but if you want to talk about that real quick.
Yeah, so that's a good question, how patients get referred to us. So patients can, first of all, self-refer. So if they were to hear about our clinic and they want to call in and inquire about it or ask their provider for a referral, they can certainly do that. But we're happy to see them if they reach out to us. They can, as I mentioned there, have another provider, any provider, refer them to our survivorship clinic. It can be as easy as entering the referral into the EMR. We use Epic, or it can be a phone call, whatever it is. And we also have automatic referrals now placed through our breast oncology clinic at Smilo Breast Center, where those referrals are entered at the time of diagnosis. And Kiki does a wonderful job watching for those referrals and tracking people out from their time of diagnosis. For example, those diagnosed with DCIS would have a quicker turnaround time after having completed active treatment, be it surgery and or radiation therapy, but we wait until they're completed with active treatment. Again, thinking about chemotherapy as well, before reaching out to see if they want to see us in clinic and discussing what our clinic does as well. I hope that answered the question. I don't know if anyone else had any other thoughts on that before we wrap up. All right, well, thank you everyone for joining us today for Talk on Fear of Recurrence.
See you in 2 weeks.
Yep, we'll see you in 2 more weeks.
Talk about fatigue, right?
Fatigue is the next one. All right, take care everyone.
Bye.
Bye.
Thank you. Bye.